A big hello to all our viewers. My name is Divya. I'm a neurophysiotherapist working at PlayStreet, Bangalore. PlayStreet is an organization that provides educational services to help children with special needs become independent and live up to their potential. We offer parent empowerment programs, an integrated schooling program, and a variety of clinical services. In recognition of Autism Awareness and Acceptance Month, we would like to center our discussions around augmentative and alternative communication, AAC. Our goal is to emphasize the significance of AAC, address the challenges associated with it, and promote greater awareness of this essential aspect of autism advocacy. And today is our 8th talk in the series. So let me introduce our lovely expert for today, Dr. Mona Patel from Gujarat. Dr. Mona is a pediatric physiotherapist with extensive training and certifications in several specialized areas. She started her career at Kala Rao CP Center, an NGO run by the National Society for Equal Opportunities for the Handicapped, where she worked as a senior pediatric physiotherapist for 3 years. In 2006, she co-founded Sparsh, a multidisciplinary pediatric rehabilitation clinic with Dr. Tejas Patil. Dr. Mona holds certifications in NDT from Neurodevelopmental Treatment Association in the USA, as well as in sensory integration and praxis testing from the University of Southern California. She has also completed courses in advanced baby care, decoding autism, vestibular vision, and therapeutic listening. In addition, she has a certificate from Aquatic Therapy Network of India, and she is an aquatic therapist herself. Overall, Dr. Mona's background and qualifications reflect her commitment in proving the best that she is in her field to give the possible care to all the children with diverse neurological and developmental challenges. Today, our esteemed speaker, Dr. Mona, will share her insights on the practical challenges associated with AAC used by the physiotherapists, providing us with a deeper understanding of this crucial aspect of autism advocacy. Dr. Mona, we welcome you and we want to thank you so much for taking time to join us at PlayStreet today, and we are honored to have you with us.
Thank you so much. Thank you so much for inviting me.
Welcome. To start off, could you tell us a bit more about your experience working with individuals who use AAC systems?
So my use with AAC started because in city like Ahmedabad, when we started practicing way back in 2006, we didn't have, we had a scarcity of speech therapists. And we cannot fragment kids, if you're working on the kids has a diverse needs, and we really need to cater them to manage them as a whole, right? And that's how we started searching for it, and that's how we started using it. So mostly we started using it for physically disabled as well as non-verbally autistics. And as a physiotherapist, my first start with AAC came with my cerebral palsy kids, who were basically in the range of gross motor function classification system level 3, 4, and 5. Where they had a cluster. Cluster means besides having a physical disability, they had multiple disabilities. They had speech delays. They had cognitive delays. So that's when we started searching for things to help them better, because what happens is when the child is physically disabled but has good cognitive abilities, and then he has a associative speech delay also, then that gives them a lot of frustration, because yes, they want to move, that also gives frustration, and then they want to express. So their non-verbal communication is good, but they don't have a way of expressing themselves. So we were looking for a lot of modification. As my primary domain is physical therapy, we started with adapting the environment more for their gross motor needs. But then we realized that more than gross motor, if we really want to help them to reach their best potential, the first thing is important that they should be able to communicate whatever they want to. And that's how we started working for it. And then obviously in our setup, when I did my sensory integration, And then I also pursued for registered behavior technician. So whenever we started a new services in our clinic, we personally thought that we really need to have official training for it before we started, and have experts from that field, so that we can really put justice to it. And that's how the autism OPD started in our setup. And that's when I took help of a lot of my colleagues and friends from speech therapy field and from ABA field. And that's when I learned a lot of new approaches also related to autism. And that's when we started using AAC for non-verbal ASDs also.
So interesting, Dr. Monu. And as you said, like mostly it is used by speech therapists and special educators, right? So that's what led you to choose AAC in context of using pediatric physiotherapy setups as well. So that's really interesting to listen from you. And what are your criteria for selecting AAC for a child, Dr. Monu? Do you use AAC only for non-speaking children, or do you use AAC for the children who are speakers but have limited language?
So if I tell you, so mostly for physical disabilities, I use ICF, so Communication Function Classification System. So usually for level 3, 4, and 5. So level 3, 4, and 5. Level 3 is where they have some form of communication abilities, but that is mostly with a known environment or a known people. They can interact better with the unknown environment. Their ability reduces, and the language ability is limited. Maybe they are one word speaker. So that's when from there on we start introducing it. And many times for autism, even when the child has a gestalt way of language processing, which is very intense, and definitely for non-verbal to we use it, but sometimes with verbal kids also who has language but a huge amount of echolalia and is becoming very difficult for them to get over it, then we provide the support so that they can express it better.
And also a few times there were kids with gross motor challenges. So how do you address them and their ability to use AAC more effectively?
So usually we use AAC. So before I explain you this, I want to give you for a gross motor challenge, as you said. So mostly kids with cerebral palsy. Okay, so there also we use ICF class model. So we use GMFCS. So GMFCS is gross motor function classification system, and it also has the levels. Level 1 being most independent child and has good control and can do everything what a neurotypical child of that age will do, versus level 5 is more severe and doesn't have head control also, right? But many times what happens, the level 5 and level 4. So level 4 is mostly the child who has an ability to sit, but might have huge challenges with using their hands. And many times this level 4 and level 5 has a gross brain damage involving all areas of brain. So that's when we see the cluster. We see physical disability, we see speech delay, we see fine motor delay, along with gross motor delay. And that's when sometimes still with these kids who are at JMFCS 4 and 5, what we see is, though the physical systems, the speech is delayed, but their cognition is still relatively better. I wouldn't say age appropriate, but better. And that's when we see they are hugely frustrated because of it. And that's where we use AAC for that.
And Dr. Mona, how do you incorporate AAC into your treatment plans and sessions? And do you only use AAC for the communication goals, or to develop some body awareness, motor and visual goals also?
So thank you for saying this. So I want to tell you that primarily my use of AAC started with while treating kids who had CP and CVI. When I say CVI is cerebral visual involvement. So what happens, with cerebral palsy kids that if they have less damage, it's periventricular. When there is primitive kids like primary kids, when they suffer some form of brain damage, it affects their periventricular area, right? And when the damage is more, that extends to their visual area, and that's when they have CP and then they have CVI. So my primary use of AAC started while treating kids with cerebral visual impairments, where I started using a lot of Apple products, because iPad had many applications for CVI, and when I was searching that how I can help them, so it started more with a CVI, and then I thought, okay, see, bingo, and I saw so much of change, because CVI kids, when the child has CP and CVI, they are very vulnerable. Their tolerance for frustration is very low. It goes like this, and they cannot trust things very easily. So that's when we saw that it's not only when we provided them more understanding, when they could see and find out things better, and that indirectly helped them to communicate what they wanted and what they don't. And that's when I started understanding the importance of that we can provide this modification for expression. It can be so helpful. And that's when from there we started using AAC. So we use it in treatment also, because I thoroughly believe that when you are treating the child, we are therapists, we are doing everything extrinsic, right? But I can put the food here, but then they have to chew it to really have it. So we need to make the process somewhere intrinsic to make that change for them. And that's when I started using everywhere. So I believe when we treat kids, we explain them kind of everything what we are doing cognitively, because we really want their attention to it. And that's how I believe that it has to be more interactive for it to go into their system. And so we just don't give them to use it at home. We use it all the time, whether it is a PT session, OT session, speech session, right? Whenever the child has a need, we really need to use it everywhere for them to get it and then use it. And that will come only when we use it as much contextually as possible. So we use it all the time. And as you said, yes. When it is contextual and when it is, it provides motivation to child. And whenever there is child's motivation involved, it gives you their attention. And whenever there is attention, you get better postural activation. So it indirectly helps us in, activating our kids' body better, activating their postural control better. So yeah, we use it all the time and it helps us.
Yeah, that sounds so interesting when you were telling us. And we can find how compassionate you were, like coming from CP and all the things for all conditions of neurological dysfunctions. You've been using that and implementing that. That tells your compassion towards the kids. And one thing we want to know, Dr. Mona, is how do you work with other professionals? Because like mostly it is limited to speech therapists or occupational therapists. And how do you make it a centralized approach for all the team members?
So I feel earlier there were huge challenges to pass it, across discipline. But I think with the time and with the technology coming in, and especially after COVID, when we did a lot of we did a lot of virtual training, we all did it. And I think after that, it has become easy overall. We have this academic sessions in our clinic where we do a combined sessions for a child. So, for example, if the child has a cluster where he's taking PT services and OT services, then we make it a point that once a month, a child, parent, and the professionals who are working on that child have a combined session along with me, so that we can have a holistic goals for that child. And then we do this transdisciplinary discussions where the autist point of views can help the PT's point of view can help the OT, the speech therapist point of view can help PT and OT. And That's where we also see that in AAC, what in terms of program, how we can have overall impact. So for example, if there are particular speech goals, then how the PT and OT can combine it in their session. So there are more practice of those goals. So this is how we interact. Within the community also, we have a good rapport with developmental pediatricians. So sometimes if the parent is resistance for it, so we take help of her also, so that if she reinforces it that the child needs it, then if it is reinforced by multiple hands, then there is a possibility that parent will accept it better. So this is how kind of we work together.
So talking about the parents, is it easy to convince the parents to use AAC, or is it tough? And how do you involve the child's family or the caregivers in this process of using AAC? And what are all the strategies you use to support them, at the child at home or in any other settings for the AAC?
So I would tell you that it's the most difficult thing. Uh, uh, I usually, what I do with parents is that I'll try to educate them as much as possible about it. Usually a parent who is on the field with us, who is as much present to the child's difficulty and accepted it and has a will to work on it. Those are the parents who are easier to manage and they kind of flow in. But then there are parents who really resist it. Especially kids with autism, non-verbal kids, they are really resistant for it, that, okay, if we will give this, they will not try to speak, right? So usually I keep videos of few kids who have achieved it. I connect them to few parents who benefited from it and had a good experience with it, and I found it that helps better than a professional saying it. So yeah, a professional saying it is a first step, but if they connect to a parent and if it goes parent to parent, then it has an impact. But then also some parents resist it. So then we let it be like that and we take one step at a time, and then we introduce it gradually with lot of support, and we wait till they accept it. What was the second question you asked?
Yeah, what are the strategies you use? So you have already explained that other than the home, in any other settings, how they can use, like, for example, if they go to any other mall or the playground.
So, you know what? Practically, our attention is usually at three things: home, school, and therapy setup. If a parent and child learn to use it at these three places, then usually parent has that thing where he can generalize and help kid use it in the rest of the places, because uh, the other places are leisure places and where the motivation of the child is itself high. So he will not resist and he'll use it, right? And it is easier for parent also. So these are the three places where we have to regulate them and regulate their behavior to use it. If they get it in these three places, then the rest is not a very difficult thing, you know.
Yes.
Also, we try to encourage play dates. We also try to have a buddy programs for our parents within the clinic, and we encourage them. We kind of channelize that, okay, we can have this groups. So we have group sessions on every Saturday in our clinic. So there's movement groups and there are communication groups which are managed in two different setups. So where parents also bond, besides kids and besides achieving our goal as group. And from there, we encourage them to have a play dates and then use there. We also have a lot of festival-based celebration in the clinic, and we encourage them to do the same, in their buddy circle. So that is how we kind of try to maximize.
That makes a lot of sense. And also, you would like to know what are other challenges apart from convincing the parents that you face during this process of using AAC, and how have you addressed them?
So, in a city like Ahmedabad, so if you know, we take a lot of support and help from Shireen. And our understanding of speech domain, a huge contribution goes to Shireen for it. So we have a scarcity of speech therapists here. So one of the bigger challenges are in terms of resources and skill, which we face, because finding a therapist is a really huge task here. And even when you find a therapist, they don't come ready for you. So then helping them with their skill training is a task. Again, finding a resources, like as I said, that mostly we use tabs or picture cards or communication boards. Earlier, we were using boards and books. Now we are using more and more tabs. But few of my kids don't have a hand function also. They are so tight that even reaching to a one place, like in iPad, if you give two only two boards, to choose for yes or no, or even for switches, uh, uh, then also it's difficult for them. So one of my child has started using eye gaze software, but yeah, again, everybody doesn't have that much of motivation and resilience, to patiently use it. Because when you start using those things also, when you are trying to train the child, it keep on clicking, things again and again, which is very frustrating for us, for parents, for child, and to pass through process and not leaving it, midway, also requires lot of efforts from us. Because what I've seen is a parent will put it aside. So that's the challenge. That's a challenge to really motivate them. The parent who is very, very motivated, usually they will get it and come to us. There is another extreme also, that okay, this I have found this. For example, I guess so way back I worked with one professor from one tech university, where I had a kid where we knew, this is, I'm talking about somewhere around 2007 or 8, where I knew she was severely GMFCS5, no control over anything, but we knew she knew so much, no speech at all. I'm talking about a kid with cerebral palsy. And but me and mother knew that she knew so much. Okay. And so we met that professor and we said, can you get us something, a head pod kind of thing? So he literally gave us a head pod. Okay. And then he gave us on the computer, he gave us 4 screens, and then he said that, you teach her to do it. And so we developed this thing, and then he gave us one very baseline software in the phone, in the mobile, which we can use it. But it was very difficult for her to manage because she couldn't hold it. Even her eyes had such a fragmented saccade. So this is the challenge many times, that the saccades are also so jumpy, so fragmented, that even with the eye gaze, she was not able to control or sustain that eye gaze on that particular point for a certain period of time. So but that's how I look for eye gaze technology, which is a lot better developed than way back then. But we couldn't continue with her at that time. So we continue to work with the cards, and then we started putting cards at distance so that we can clearly see what she wants. And then we trained her for that head rotation. But this is the bigger challenge, also, if I do we have time? Can I say a few more things?
Yes, go ahead, please go ahead.
Yeah. So we as a professional also need to understand, when we are applying these modifications, that the core, the trunk is the base. Okay. For your head and your limbs to move effectively, you need to have this trunk aligned and controlled. right? So when you're working with the child who has more disability and has less control and doesn't have a control over his or her trunk, then it's and not over the hands, so that he can tell us or he can choose something with the hand. Similarly, it is going to be difficult for that child to have control over his head, right? And many times for choosing this boards or this devices requires a very finessed control of the head movements or the eye movements. So we we can work on it, but for that we really need to understand alignment. We need, before giving that eye case technology based tool to them and train them for that, what we need to train them is for providing them the correct sitting or standing arrangement where their whole body, especially their trunk, is well aligned. So if the trunk is well aligned, then and then only you can train their head for better posture and better alignment and better control. And if the head is controlled, then with that you can control, then you can teach the child to control their eye movement, right? So this is the process. Like the child is sitting in any alignment, child is sitting in your lap, and then you are trying to patiently help the child with head movements and the eye movements. It's not going to work. So it's very important for parents to learn and understand that we need to take 24/7 postural care. If we want the child to communicate with using the AAC, especially with the physical child, when they really want that the child has a potential and child should be able to explain, we really need to help them get in correct alignment in whatever sitting aid or standing aid we are providing. We need to teach and work on activating that trunk, because only when you activate the trunk and has some control, then only they'll be able to use it. Okay. There's one more thing which is there for the kids who are good cognitively but has very bad control of the body, is that along with that sitting chair there is something called head pod. Now head pod gives a little bit of traction and takes the weight of the head away. Okay. And then you have a good sitting arrangement where your trunk is aligned, and it also takes the weight of the trunk little bit away. So then the muscles of the trunk and head, whatever little control also you have, with your support and with your guidance, the child will be able to use, because the child's cognition is there. And if you use those two systems and then put that eye gaze technology in front of them, there is possibility that you'll be able to train them a lot easier, in a lot easier way, right? So many times I see a lot of videos for AAC, where they're using it for the child with physical disability, and they are asking them to do it, through eye gaze, but the child is sitting in a really bad posture, like in a recliner chair or but that's what I want to say, that if you really want to use it, then please understand that alignment is important. And this is not only for CT, even with kids with autism, because if you are training a child for AAC, the child is going to use it for communication, because means it is throughout. So then it's very, very important that where you place it, right? If the child is all the time using it here, right, then it is going to really hamper the cervical spine. So it's important that we have a wall mounted, a wall, like anything to mount on, the tabs, right, where the child is using it. So that child is not losing out on his posture and doesn't develop a secondary problems like pain, right, bad postures. Because we know, I think 66% of ASDs also are low tone. I am not too sure, but yeah, more than 50% for sure, right?
Yes.
So they also, their body does, that proprioceptive system is not working that much, right? So we really need to help them there, right? So literally in our clinic, all kids with ASD also, especially the ones who are low tone, they are given some form of vest which gives pressure, so that it gives them a sense of pressure, so they are a little more regulated. It helps them regulate, as well as they are more connected to their proprioceptive system, and so their body awareness is better. So they they maintain better posture throughout the day so that they can learn better, right? So I want that people should understand these things while they are trying to use this technology, that if they take care of the posture, it is going to help them use these things better.
That is so much informative. And we want to know how long did the kid take, the kid who was using a headboard, how long did the kid take to communicate, and how long did she take to improve the eye gaze and a posture?
So we have only 2 kids, right? So far, because headboard is very expensive also. So not all of them can, afford it, right? So chairs are very expensive, headboards are very expensive. I guess everything is very expensive. So not everybody can use it. But yeah, it takes. So for the 2 kids, one is still underway, getting trained for it, and the other is, I think it took somewhere around 9 months to a year to use it in the baseline, you know, still a long way to go. But yeah, at least yes and no, choosing from 4 to 5 options has reached to that level.
Yes. Then she's really getting better. And we
Yeah.
would like to know in what other adult conditions can we use AAC, and also what is the awareness rate of AAC among us physiotherapists?
Oh, I would say very limited. Awareness among physiotherapists, I would say very, very limited. Our attention doesn't go there. So I think it will improve. I think with time, I think that's how I am here now. There are a lot of collaborations are happening. I think with the technology, I think a lot of things are happening. And I think every therapist realizes that you cannot fragment it. You need to have a basic knowledge of everything, because now parents are also well aware. They come and put you into that zone where they ask you a lot of questions. But if I say that how much motivated PTs are, then I would say, yeah, the long way to go. But I think gradually it's coming there. I feel the places like Ahmedabad, I might say we PTs are more aware because we don't have a good speech therapy support. Because when you don't have support, that's how I got it. If I would have somebody, then I would have not paid attention to it at all. So it's still there. So I all my friends here, they keep looking for things. Okay, I have this, what do I do for it? So that's how we learn also. That's how we reach to people like Shirin, that okay, we need help. So recently I called her for one of my kid with hearing aid deficit. Okay, and the child had 5 BERA reports, and all of them had different results. And I was looking for somebody who can do the auditory integration therapy for him. And the parent had taken so much of therapy but never heard of it. So that's when I called Shirin that, okay, I want you to see this child. So I think it's becoming better. I think it's becoming better for sure. And for adults, well, practically, since I don't work with adults, the answer is I don't know. But I have friends PT friends who practice exclusively in adult neuro. And I would say a adult patient is a lot more demanding because he has lost something which he had. Okay, and so there they look for it, they ask for it. So I feel it's better than kids, definitely.
And what are the other common AAC devices and tools that you have worked with? And can you discuss those pros and cons related to them, and how you tailor them according to the child's needs?
So see, we started with using the cards. Okay, then we started using cards fragmentally. We started using these communication boards which were available free. Okay, So we made the communication books. Then from there we went to the tab, and mostly we use Avaz. And a few of my patients from abroad. So I got another app, which is LAMP, which is again really good, especially one of with non-verbal ASD. We saw that he was using it so well. So that's when, if people could afford, so then we provide LAMP to them, because it's easier, even easier than Avaz. But even Avaz now, with a lot of modification, has become very, very it is improvised. It's a lot better. Then, as I said, I have seen two parents use eye gaze, and then because we got that, because parents agreed to do it, we started using it with them. So, and with one patient, I've used switches long before. We don't use switches now, right? If anybody doesn't have it, then we use some apps in iPad, right? And we start from a very baseline apps, and then we progress with whatever is available. So these are the kinds of we use. Earlier, we used sign languages also for few kids, but now we realize that with physical disabled, sign language is extremely difficult. With ASDs, again, a lot of them the way they have apraxia here, they have dyspraxia in their body also, a lot of them. So signs are difficult for them to manage, mostly. So we have ABA also, so we used to do MAND, so we used to do a lot of sign mends also. And we realized that because they have their window of tolerance, so they being either hyper aroused or hypo aroused, their optimal level of arousal window is very narrow. And so we saw a lot of collateral behaviors happening. So when we are teaching them signs, they will then try to do everything, together, this or this. So if we keep it less and we keep it generalized, then they learn it better. But if we keep it generalized, then we are not teaching them more language. So again, doing an errorless teaching was very difficult. And we saw that when we were practicing ABA, that when we are teaching it, just, as a reinforcement base, and the parents didn't supported it contextually, then there was a lot of as I said, it was overlapping, and there was a lot of collaterals which were developing. So he'll do this, and if we delay in giving that, then he'll do something else also, right? So because you are teaching the motor imitation skills also simultaneously, you are teaching receptive instructions also simultaneously. So sometimes it becomes too much for them, and then things overlap. So the signs I saw in my experience, I don't know what is your experience, but beyond few, it becomes difficult. What do you say?
Yes, it does, because every child will not have the same motor ability to continue with the gestures.
Yeah.
And how do you stay updated with the advancements and changes in the field of AAC, Dr. Mona, and integrate this new research and all the best practices into your work with the pediatric patients?
So, you know what, as a clinician, as you know that looking for results, there was a time in 2016, 15 when I thought, okay, I think I am kind of an average PT, because I kind of produce things, but they don't stay up, and then kids are frustrated, parents are frustrated, and I am frustrated. That's when I started looking out for a lot of things. And that's how I got trained for aquatic therapy. I got trained for postural care, alignment care, lot of orthotic garments, which provides alignment care. That's how I learned for Theratox. That's how I learned for correct A pose. That's how I learned a lot of things. Like for autism, we did a lot of things with them. So I learned a lot of skills. Like we did floor time. We learned certain aspects of Hanan. We learned certain aspect of Hanan. I learned, my primary understanding of AAC came from a parent who did extensive research for their child because the child was very frustrated and I was having a very difficult time in the school with the teachers. Because what happens, therapist has a lot of patience, parent has a lot of patience, but many times teachers, though they have a patient, it's difficult for them to manage because they have a group with them they have to handle. It's not one-on-one. So that parent motivated me, and a lot of my understanding and motivation came from that parent. And then I started reading about it, So I would like to say thank you to Smayan's mom. My understanding of AAC improved a lot better. And after seeing her, I started applying it to other kids also in my clinic. So yeah, I read about it, right? And as I said that we are still primitive in terms of taking, it in a very structured manner, step by step. But we have seen the improvement we got with it, and we really want to do more and more. So yeah, I kind of read research. I see what is happening around the world in every area. And when we started making a lot of improvement, I realized that if I make those improvements and if I don't help child use it, then they are not going to sustain, right? And basic communication and using body for communication, So if the child is able to communicate, then he is able to engage into whatever he wants to engage into, right? So language and motor systems are so interrelated. I mean, you cannot fragment it from each other. If you want to be that whole person you are, you need both. And so if I am a firm believer that, okay, for brain to learn something, you require a few thousand repetitions, and that repetitions also has to be natural contextual. If it doesn't come, it will not sustain. And with my kids, I've seen it that transforming something into long-term change is how difficult. But I've also seen it that it is possible. You won't believe we have made changes in the GMFCS level. As a PT, you might understand. I would like to explain it that we have made changes in cerebral palsy kids in their gross GMFCS level in second decade. Okay, so we have made a level 3 child reach level 2. Okay, the research says that you cannot change MFCS level after 6 years. And for the longest time, I believed it, right? I don't say that I can make a GMFCS 5, GMFCS 3, or GMFCS 2. That's not possible. But you can definitely, if you work correctly, if you understand alignment and then you work on it, then you can make those changes. So my understanding of this, a lot goes to Karen Papp. She's a neonatologist who has done a lot of work. You can hear her. I feel every therapist and every parent should listen to her talks, coming from a medico, she understands brain, body so well connection, okay? And that's when I understood that a damaged brain has an issue, but it can grow and learn, right? But it usually gets masked by faulty habits, right? So if you correct the habits and then help them do that few thousand repetition in that correct habit, you can make a change, right? And that goes everywhere. That goes for speech, that goes for any gross motor ability, that goes for any fine motor ability. So in our clinic, we are very intensive based. A lot of people come to us for intensive protocol where we do at least 2 to 3 hours a day. It's a block. It's not we are going forever. It's a few month block, but we do that. And that's when I realized that, okay, if you do practice at that level, so I always encourage parents that if you want child to accept it and understand it and being part of, when we give AAC, we want child to have it as a part of their body. We want their brain to accept it like that. Only then they are going to use it. Otherwise because it's an external thing, right? So I usually try to explain these things holistically to the parent, and I explain them how our brain works. I feel for all the therapists and parents, we have to understand this, that if we want to make a long-term change, we need to put that level of effort. We all talk about that, okay, child-centric, family-centric models, we really need to support in the way they want. Yes, absolutely, absolutely. But brain is a complex thing. Okay, autism, cerebral palsy, these are the developmental conditions. Okay, we have something in a growing brain. Okay, it has that implication. It's not a baseline which is going to remain flat, right? If there is a mindful parent and a skillful therapist, it's going to go up. Okay, if nothing has been done on the child, then it's not going to remain flat, it's going to go down. The child is going to go into chronic habits, right? Chronic small form habits, which is going to make them very non-functional, and it is going to have huge implications. So it's a complex thing. We cannot have a life, which is settled. We can have it, but we have to remain mindful here, because if we want them to be baseline and little up, we need to work on it. So if there is a logistic difficulties, we help them at home, but they have to work at that level, at that intensity, frequency, duration, so we make a change, right? If we don't, it's not too much of quantity, but yeah, quality. And that quality is mindfully repeated throughout the day, contextually. Sorry, that was too much.
No. That's actually true, because we fine tune the kid into a normal movement or a proper movement, and then we increase the repetitions so that it will obviously form a neuroplasticity in the brain, right? So
and that goes for that goes for everything. That goes for a speech therapy, speechist, that goes for us. That's how we are,
True. Yeah, and also, can you share a case study of a child who benefited from AAC implementation in their PT treatment? And what are some of the key strategies or tools that you have used and supported the child's overall development and well-being?
Yeah, so this is what I want to share the case of Smayan. So Smayan is a very intelligent child. He is GMFCS 5. So he can support it sit for some time now with a lot of help, right? But otherwise, he has challenges, and he has a lot of tone issues. Okay, and so he has little bit of ability to get that right hand front and choose option. And this was a child where parent had given a lot of books, from beginning, and even therapy. They will read the book and then they'll ask Mayan to show things into those books, and that's how we'll do the repetition. Or they'll ask, okay, now you change the page, turn the page, So that's where I got really motivated from. So they used lots and lots of books with Mayan to start with when they were training him. But there were huge issues. One, because Smayan had huge issue with transition and anxiety, So if there is a change in a routine, if there is a change in exercise schedule, if there's a change in the therapist who is training him, like they came to me from Mumbai, and that was the first time, and more than Smile. So mom is really well regulated, but had a doubts in his mind whether, so she told me that, okay, he might do few things with you. I don't know, we are coming for 10 days, but luckily we went into water and he did phenomenally well. So from there, I saw, we started working with him, and we used those books initially. Right from there, gradually we started putting Smayan on iPad. She put him on iPad, and then earlier she did yes and no with the two windows on the iPad. Then she got Avas, and then we started using Avas. So mom made it a point that we use it everywhere. We use it in the clinic, we use it at home, we use it in the school, and we saw that with help of the iPad, Smayan started interacting way better. And the best change what we saw is in school, right? That he was less frustrated. And so the Smayan had a caregiver who used to go with him in school also. Okay. And the caregiver was there with him at home also. So, so mom and Smayan, me and Smayan's another therapist trained the caregiver, and then they started using it. And they started, he becoming better and better, right? And one of the major thing what I saw is that beyond yes and no and choices, we knew that Smayan had so much to express. And we started using those words in Avaz also, but then also there are 5 words, and then there are few things, so need-based commands, So with Avaz, he started doing need-based work, he started doing choices, and then mother thought that, okay, what about if I need to provide an opportunity for communication? My understanding to this level also kind of came from this, because many times as a therapist, you teach parents, but only if the parent is persistent, you can take the child to next level. And this requires a lot of effort. This was a rope. This was like a thing for me where I saw that, okay, he's improving so much, and this helped with our therapy also, because when he's engaged, his tone is also low. So then it becomes easier for us to work also. And from there only, she was the first one who got the eye gaze to us, and then I saw it, and then she only shared a lot of videos of it, a lot of therapists doing it, and I started seeing them, and that's how we started doing it, right? And the other, and he's doing a lot better. They are training him. There are frustration because it gets selected, but I know. So we have a phenomenal OT, Smiles OT. Her name is Hiral. So I know these 3 people are so awesome. They are going to, figure it out together nicely. And I feel they are going to really put a nice example. I told Smiles mom, that is the video I'm going to share with you, where I want her to, talk about her journey. I feel that is going to be very rewarding. And the other is my another child, a 5-year-old, has apraxia, autism, and has only, nothing else. But we've trained him, and gradually he writes everything. He gives answers to WH questions. He writes all his needs. He communicates so much more with it now. He goes to school, he uses it there, he uses it home. I mean, he has come to a level where if the device is not around, he'll go get it, and then he'll tell us things, So this 2 things were like a very like a game changing, eye changing, whatever you say, for us. And from there, we become a lot more sensitive and a lot more present to provide it, and explain it. I usually connect all my parents to these 2 parents, for physical disabilities, Mayan, and then this other kid, So,
where teamwork comes, and also the video which you will be sharing with us will motivate many parents and many caregivers as well, because they have kept their heart and soul in it. That's why the kid was actually improving.
Yes, so I feel with AAC or with anything, which is where we have modified the environment and provided the aid, right? A parent plays a huge role into acceptance and real time use, no matter how motivated you and me are, if the parent doesn't do their part, then it doesn't become functional.
So with this, Mona, we have come to the end of this interview, and I want to express my gratitude to you, Mona, for sharing your expertise on AAC and its impact on children with autism and cerebral palsy and many other conditions. your insights into the importance of incorporating AAC into the treatment plans and sessions, and also the challenges which you faced and what all opportunities it gives, like changing the posture and all of this it presents. They are all incredibly informative and enlightening. I feel like this talk with you would encourage other physios to use AAC as well. So, Dr. Mona, we truly appreciate your time and contribution to this important discussion. On behalf of the PlayStreet team and our audience, we extend our heartfelt thanks for your valuable insights and expertise.
Thank you so much. I would really like to say that PlayStreet is doing amazing work, all of you there, right? And I would like to say thank you to Shireen. It has been amazing support, and whatever we do, a huge piece of it, especially when it comes to anything related to speech therapy, comes from her. So thank you so much for inviting. And thank you so much for what all you do. It's inspirational.
Thank you so much for those kind words, and you're most welcome anytime to share your knowledge with us. And we hope that our audience gained a clear understanding of AAC and its vital role in physiotherapy and empowering individuals with autism and many neurological dysfunctions to communicate more effectively. By addressing misconceptions and promoting a shift in mindset, we can provide the support needed for every child to have a voice. Let us all work towards creating a world where everyone can express themselves freely. Thank you, everyone, for joining with us. Have a great day now. Bye-bye.
Thank you. Bye.
Which book you are reading today?
Autumn naughty bird.
Yes, Mayu is reading this book. What a naughty bird. Smile. Chal, let's open the book and tell me that on whom did the bird did poo-poo in Africa? On whom did the bird do poo-poo in Africa?
Autumn naughty bird. Elephant.
Elephant. Very good. She did poo-poo on the elephant. Naughty bird. What do we say to such a bird?
Autumn naughty bird.
Yes, we say what a naughty bird. Then let's turn the page. Let's turn the page and see what is happening next. Who has come now? Whom did she? Smile. Whom did she make friends with? Whom did she make friends with? No, not elephant.
Shark.
No, shark. No is no one's friend.
Today is our 8th talk in the series, and in this, we are in the 3rd segment, which focuses on the AAC paradigm and where all it can help for the OT settings. So the topic for today is empowering communication and movement, the crucial role of AAC in an OT setting. And we are honored to have Ms. Miraclyn Lydia with us to share her valuable thoughts and information on the same. Let me introduce our lovely expert for today, Ms. Miraclyn Lydia. Miraclyn Lydia is an occupational therapist currently working at PlayStreet. She has completed her bachelor's from Christian Medical College, Vellore, and her master's in the specialization of developmental disabilities from Manipal. She has experience working with both adults and pediatrics as an occupational therapist. She's a warm and fun-loving therapist who works closely with parents, caregivers, and other members of the child's team to ensure continuity of care and maximize progress. She is passionate about her profession and also helping each child reach their full potential and achieve their individual goals. And she believes that every child is unique in their own way and should be allowed to express themselves in whatever way they can. So today, our speaker, Miraclyn Lydia, will share her insights on the practical challenges associated with AAC being used in occupational therapists, providing us with deeper understanding of this crucial aspect of autism advocacy. Miraclyn, we want to thank you so much for taking time to join us today, and we are honored to have you with us. Could you tell us a bit more about your experience working with individuals who use AAC systems?
Thank you, Divya, for the wonderful introduction. And yes, I would give you some insight about my experience. So I work with children who have autism, and most of the children that I work with are nonverbal. So their main way of communication is through AAC. So as an OT, so it's a common myth that I would say that AAC can only be used in speech therapy, only during speech therapy, and only for speech. But then that is not the truth. So as an OT, we can use AAC in our therapy also. So when we talk about OT aspect, so we work on children's three main domains. So we would keep it like ADL, which is self-care, then work, and then comes leisure. So as children, work would constitute as school or being a student and that. And their main leisure would be play. So as we see, children's primary occupation is play. So we have to give more importance to play as much as we give importance to ADL and school or other work that we do. So OTs can use AAC in all of these aspects also. So that would improve their communication, their wants or needs, which will help the children express what they need to the therapist, to the parents, or to everybody. And again, that back and forth communication. Again, when the other person also knows what the children requires, they would be in a position to give them much more appropriate answer instead of just assuming, okay, this is what the child wants. So when a child is using AAC, that is something that we are focusing on. So I would like to show a presentation on the basics of what as an OT, how we approach this AAC. So this is a model that we in occupational therapy we use to assess and also to use it as a goal, as a milestone to see how much the child has progressed and all. So this is called the person, environment, and occupation model. So you see these three circles, they all combine here, they overlap here. The place that they overlap is what we call as the occupational performance. So when the person means the child, the individual that we are treating, and the environment. So what environment they have to work on or what environment they are currently in and all of that. And occupation, when all three interact with each other, and when all three are in sync, we get the maximum occupational performance out of it. So I would be talking about each domain. So person. So person is the client that we are seeing. So in my case, I work with children. Right now, I work with children with autism. So the person refers to children with autism right now. So this, I'm going to talk in relation to AAC specifically, no other things I'm going to talk about. So under the person, these are some of the skills or these are some of the characteristics that we look when we do an AAC evaluation or when we see, how much the child has the skill to use an AAC or what type of AAC skill, what type of AAC device the child has to do. So the physical skills, so it comprises of all your fine motor and gross motor skills. So how much of a strength the child has, how much of a fine motor the child has to touch the screen or show, to pinpoint which picture or how to type, and all of that comes under physical skills. And so under cognitive skills, your attention, concentration, memory, your processing, your sequencing, and all of that comes. So cognitive, we do not look at cognitive skill as a prerequisite for AAC. Cognition is important for a child to remember and to understand how to use the AAC and all. But if a child comes to you with a cognitive deficit, that does not mean that the child cannot use an AAC device. The child can very well use an AAC device, even though the child has cognitive deficit. So you cannot reject a child saying that the child is not fit for an AAC because the child lacks cognitive skills. And then you have sensory processing. So what type of is the child sensory avoidant, or is the child sensory seeking, or does the child have low registration? So all of these come into play when we look at an AAC evaluation for a child. And then we have socio-emotional factors. How is the child emotionally regulated? How is the child in a social setup? Most often when children come here, they, since they are non-verbal, they don't mingle much with other kids because the main reason is they do not know how to do it. There is no question of if there is an interest or not. Every child has an interest to socialize with other children. The only reason why they're not able to do that is because they don't know the means of communication is cut. They don't know how to approach a child or how to approach someone else to ask them to play with them or to ask them to share toys with them. So those factors all come into play when we look at a person point of view. And language skills. So we can categorize children into three ways. So you have speaking children, minimally speaking, and non-speaking. So again, the type of AAC device or the components in the AAC device differs for a non-speaking child, and it differs for a child who's minimally speaking. So that also comes into play when we look at the person factor. Then we have the environment factor. So when it comes to AAC, we need to look at three domains under environment. So we have the physical environment, which is at what all context does the child have to use the AAC. So most often what we see is they use AAC only in therapy. Maybe in school we use. But again, when they go to their house, they don't use AAC. Or if they are taking their child to a mall or to shopping or to a park, they do not take the AAC with them. So mostly it's limited. So again, looking at what all situations they are supposed to use and how to incorporate that. So that comes under the physical. So it can be a school when they are in school. So you can tell the teachers, you can tell the staff who all are working with the child that this child requires AAC for communication. So thereby improving their participation at school, then at home, then at therapy, then at park, then at every place that they go shopping or anything. So that will help them improve their performance. And then the social environment. So social environment consists mostly of the people that they interact with, kids, therapists, teachers, parents, relatives, friends, all of that. So they also play an important role in making the child independent in the AAC and the cultural. So cultural aspect when it comes is language is universally not the same because in each culture they have different words for a particular thing. And based on that, again, this all we assess to see how much of a modification it requires in the AAC device. So culturally, what all things are appropriately that we have to put. There are some things that they may not use at all. Some kids they may not use because it's there in their culture. They don't use that. So we don't need to put that. So we may have to remove that, or we may have to modify the word that we are using. So all of that factors come into play when we look at that. Then the last is occupation. So as I told in the first point, like we have work, we have play, we have ADL, and we have social participation. So these are occupation, it means that these are the areas where the child has to use the AAC. Because if the child does not use AAC here, their mode of communication is cut. And if one is affected, then the overall gets affected. So this is the basis that we use for assessing and also to show the progress, to look at the progress. So as I said over here, so we have three. So this is the person. So here is the person. And here we have the environment, and then this is the occupation. So when all three interact equally, that's when here, this area that you get is the occupational performance. The overlapping that you get here, that's the occupational performance. So what we try to look at from an OT perspective is the occupational performance should be bigger. So for that to happen, the overlap of person, environment, and occupation has to come together. So I had a child here. So he had environment, then the family support, the socioeconomic status were all good. They had excellent family support. They got a new tab. They subscribe to an AAC program and all of that. And the occupation also. So we were trying to use it for him in therapy and in speech and occupational therapy so that he could tell us what he wants and everything. So the E and the O with this child was fitting. But when it came to the person, the P category, his skills, so this child was emotionally very dysregulated. So emotionally and sensorily, he was very dysregulated. So during that time, when the child has a lot of meltdowns and a lot of dysregulated behavior, we were not able to use AAC, give the AAC device for him to tell us what he wants or what is he feeling. So when that happens, there is a huge disconnect of person from the environment and occupation. So when that happens, the occupational performance or the fit among the three reduces. So when that reduces, then there is a reduce in the use of AAC. And again, there's a reduce in the communication between the child and the other person on the other end. So what we try to do as an OT is maintain the fit so that the child can be independent in whatever he does through AAC. So I hope I helped in understanding of OT role in AAC.
Yes, that was a detailed explanation of how you use in the OT setups. Thank you for that, Miraclyn. And what are the benefits you see using AAC in your clients?
Okay. I think I've spoke about it little here and there. So first, using AAC for a child who's struggling to speak or who's struggling to communicate their needs, it directly relates to increased communication, which again relates to increased social participation. So when a child has a medium where he or she can just point out a picture or just type and tell what he or she wants, then their mode of communication is activated. So they have this feeling of confidence that, okay, this is what I want and I have this device or whatever AAC that they have, and I can use this to portray what I want, get through to the other person and explain that this is what I want. So increased communication skill and social participation is a huge benefit that I see. Again, if we take in different setup, in a classroom setup or in therapy setup also, this AAC device, using of AAC device gives them equal opportunity, because in a classroom setup, there is no one-on-one for them. They have to sit in a group, they have to answer in a group, and they have to participate in a group. So if there is a time where they want to give an answer to what the teacher is saying, again, they have an equal opportunity along with the other children to communicate what they want. And so this improves and increases their participation and their inclusion in all games or group activities, and all of that increases. And then apart from speech therapy, in OT or in any other sessions that they have a say in what they want to do or in what order they want to do. Because if we do not use an AAC device, all of us as OT, we can just be like, okay, so this is the activity we are going to do. Come, let's start. There is no input from the child in that. But when there is an AAC, it gives them a way to tell, like, okay, I would like to do this today, or maybe I don't want to do this, or I would like to do this activity first, and then I would like to do the other activity. Again, participation, which increases their participation. They'll enjoy because they are also included in the decision making. They're also included in the activity participation, choosing of the activity. So that gives them a sense that, okay, my choices, my decisions are also in consideration here. So their participation increases for them. And their so emotional sensory regulation increases because when they try to say something, when they are not able to put to the other person, like, okay, this is what I want, but when the other person is not able to understand, frustration, their patience goes and they get angry, then it comes out as a tantrum or a meltdown and all of that. But then when they have a mode of communication, they can very clearly tell their parents or their teachers or their friends or anybody that, okay, this is what I want. That is not what you are thinking. So again, back and forth, two-way communication, it facilitates two-way communication. I am able to understand what the child wants to tell, and I am able to give an answer appropriate to what the child is asking you. So sensory and emotional regulation enhances in that. And there is also improved family relationship. So because of this, they are able to tell their family this is what they feel, or this is something I'm uncomfortable with, or this is what I want to eat now. I'm hungry, I'm thirsty, I want to sleep, I want to play, all of that. So they get to spend family time. They're able to tell the family, so the family relationship improves. So I feel when all of this improves, their sense of self-esteem, their self-confidence increases, and their independence increases. Now they do not have to worry about, okay, did they get me right? This is what I'm trying to say. Did they understand? No. They have a device, they can type or they can point out to a picture and say, this is what I want. So they're independent in what they in telling them what they want, which reduces any more hindrances to their performance.
Yeah, everything what you say makes sense because if all these components are working, the kid will have more confidence in communicating. So, Miraclyn, I have a doubt. We have our very own AAC app, that is the Play Talk, and sometimes we use other apps if the parents have already installed it, right? So now, what helps you decide which app to use for the children? Is it like a team decision, or do you have to base it on any other criteria?
Okay. So when somebody approaches us for an AAC device, so it's usually a team decision. It's not like just OTs are involved or just speech speech therapists are involved. So it's based on a complete team effort. And so speech therapists, they do their set of evaluations. Occupational therapists, they do their set of evaluations. Again, physiotherapists also, they do their set of evaluations, and they tell that, okay, this is where the child's level are. So this is where the child is at speech level or motor level or cognitive level or emotional social level, and all of that when comes together, that helps us in making a decision as to what type of device or what type of AAC program a child can be given to. Again, and I said, as I said, it's a team decision. Again, based on the individual's level also. Their motor skills, fine motor skills, their sensory, their perception, and all of that. And also, apart from the child, we also look at the device. So, how is the robustness of the device? How is the flexibility for, in different situations, can it be used? Is the when I click a picture, is the word coming immediately, or is there a lag, or is the device crashing very quickly? Then if something like that happens, then we cannot suggest. Or also, we also look for a device or an AAC program that can be used in multiple devices, not only just for one device. And it is also easily accessible by the child. So all of these we use. And yes, PlayTalk is free, and that is what we have our own app, and that's what we use. But sometimes children do come, parents have already installed another AAC device, AAC program that we have to, see how it is, and we do train them based on that also. So yeah, and another thing that we look on is the accessibility, the family support, or the socio-economic status of the family. So we cannot prescribe or we cannot give a very expensive AAC program saying that no, this is what your child requires. That is not it. So based on their SES level also and how much the need is, so we suggest AAC programs.
Miraclyn, how do you educate the clients and their families or caregivers on using AAC devices for activities other than the speech or special education? How do you convince them that every opportunity requires communication, even during motor or sensory inputs?
So yeah, the first step when we usually tell them that your child would require an AAC device is just like they usually do not accept it because all parents want is their child to talk. So again, it is a little difficult in convincing them that giving a device, a tablet or an iPad for an AAC is the best way that your child can communicate right now. So what we can do is we can demonstrate to them. We can bring them in on during our therapy, and we can let them observe and see how much involvement their child has with an AAC device compared to when the child is not given an AAC device. So again, demonstrating that child is having a mode of communication to tell what I want to do in this session, then showing them that okay, it is improving their participation, it is helping them have a voice. Again, that is one way of convincing them that their child will benefit from AAC. Another thing that we can do is we can train the parents because most of the parents just think that okay, this is just I give the tab and they just like click pictures and they just say that, but then they don't understand how AAC works. So giving them hands-on training, showing them like this is how you train your child or this is how you also respond to your child during an AAC training. So that will again help them understand about AAC and why it is required for their child. And also giving them the opportunity to customize for their own child based on the settings that is used or based on their cultural beliefs or cultural routines that they have, customizing and also customizing it based on the child's level of understanding or their fine motor level or their perceptual level. So helping them understand it's just giving the tab. We're not doing that. We're also customizing it personally for your child so that it's easy for your child to use that. So again, telling the parents that this device is going to be just for your child. So it will be easy for your child to communicate. And again, beyond this, then giving them more information like this is these are some of the stories of children who have used AAC and how much independent they are, or getting them into a support group where they hear other people share about AAC, how their kids or how they've used AAC, and also those all help us in convincing the parents that no, AAC is not a bad thing, like it's a required thing for communication.
So apart from convincing the parents, what are the other challenges that you have encountered while using AAC in occupational therapy, and how have you addressed them?
Okay. So, like I said before, it's a very common myth that, AAC is a speech thing, like OTs or PTs or teachers and all, they're not supposed to use and all of that. So, breaking that barrier and telling them that, OTs or PTs and any therapy session we can use AAC, that is one thing. And the main barrier or challenges that I have found is the denial of parents, like I said, because all the parents want their children to talk, but they're not ready to give an alternate mode for their child to communicate. What they don't understand is okay, if my child has to communicate, it has to be through mouth. The child has to verbally speak through the mouth. And another thing is there are children who are verbal, but they would still require AAC device. They speak well, but they would still require AAC device. Again, telling the parent that your child requires this uh, to fine tune their communication, to help them form sentences so that they'll be able to put forward what they want. So that is one of the main challenge. And another thing is, even if a child, if a parent accepts, okay, my child requires AAC, they will send the tab to the therapy and all of that. But the AAC will be limited only during therapy. So when we try to tell them that you have to use it at home or anywhere, they do not use that. So again, that is another challenge, because then the child's mentality is that, okay, only when I come for speech therapy or only when I come for OT or PT, that is when I have to use this. That is when I type and I tell them what I want. But then at home, I don't have to use it. And convincing the parents that it has to be used in everyday scenario at home, even though you understand what they are trying to say, but making them use an AAC will improve their communication not only inside the house but outside in the society or in the community as well. And then another thing is, if they think that, okay, my child does not have adequate skills, so I do not need to use AAC. But that's not a correct thing, because we can use AAC even if the child does not have adequate skills. That's where your modification comes into place. That's where your customization comes into place. So with all of that, we could make the child independent with AAC. So these are some of the challenges that we have faced.
So, Miraclyn, how do you collaborate with other healthcare professionals when using AAC in occupational therapy?
Okay. So the main collaboration, it happens with a speech therapist, because you talk to them about the different AAC device, different methods that we could use. And again, you can also, as an OT, we can give suggestions on how to modify the AAC or customize the AAC as per the client's level, the child's or the individual's level, and how many pictures to keep in one page, or what is the size of the picture that could be, and all of that. Or what is there be a definite difference in the background and the picture and all of that. So those kind of modifications, again, you could collaborate with speech therapists, and we could also collaborate with special educators, physiotherapists for more inputs on what all other modifications we could use. Because from a physiotherapist perspective, we could have the based on the strength or the movement, the muscle range, and all of that. They could give inputs, and as special educators, how to modify it for a classroom. What are the things that we have to keep, and all of that. So collaborating together as a team for modifying the AAC is one thing, and again, collaborating with the AAC technologists, when they bring up new updates or new features. So how can they do it to improve their child's perception or cognitive skills and all of that? And again, other thing is collaborating with the parents. That is the majority of our work. We teach the parents that you have to use it everywhere, and teaching them, training them, showing them videos on how it helps. That creates an impact for the children.
Miraclyn, how do you ensure AAC devices are integrated into a client's daily routine?
Okay, so first of all, we talk to the parents or we talk to the client, and we recognize their routines. We identify what is the recurring routine that they have and what are the things that keep changing. And so knowing their routines is the first step. And then again, based on the routines, you can set goals. Like, okay, so we are going to be using AAC in this aspect. And these are the things that we have to incorporate. And again, we have to keep reviewing, and we have to keep changing the goals and the plans also based on how the individual or the client performs. And customizing the AAC device based on their routines. So this is where you add all the school stuff, and then you have a separate page for house, separate page for ADL maybe, so that it's easy for the child also to pick up. Okay, now I have to take bath, so it's in ADL. So they just have to click, and then when they go to school, if there's a folder called school, it's very easy instead of them, moving through pages to see where is the break picture or where is the bathroom picture. If we just put it inside a folder called school, it's very easy for them. Again, if we create a folder saying school and add all the things that they like or all the things that their parents cook and everything, again, they just go to the food folder and they can choose whatever. Again, customizing based on their schedule. Again, adding the toys they like, the games they like. Because if we just put like I want to play and not put any of the games or any of the toys that they usually play with, then it does not make sense. So adding those, all of that, incorporating it, that would also help a child or an individual use the AAC better. And using so AAC is not just a device. It can be low tech, high tech. It can just be pictures, taking a piece of paper where the picture is and then showing. So again, you can create a visual schedule so that they know, okay, when they wake up, like, okay, this is what I have to do today, and they can either cross it or they can like pull it out, saying that okay, I've done all of that, and then training the parents to ask them, because most of the parents at home, they understand what their children want. They may not have to even verbally say, they may just like point out and then they will understand. Again, that would hinder them in using in AAC in the long run. So even at home, if they want to do something, tell them to use a AAC device or show them like this is what I want to do. And then again, back and forth communication. When the child is asking you something, then you respond to them. And training the parents, and then you reinforce it. So you don't always have to give a chocolate or a toy or something because they're using it. But then a verbal reinforcement, just like an appreciation. Okay, yeah, good, that's all. And that again, another reinforcement is like, when they get the gratification, like, oh, okay, I am able to use the AAC and I'm able to do things like ask somebody and they're responding. So that itself is a reinforcement for them, which will lead them to use AAC more and more. And then one main thing that parents have to know is that you don't have to start using it 24 hours a day immediately. Maybe you can just start using it at home for while taking bath or while brushing or eating or sleeping. And then you slowly introduce it when you take your child to the park. And then you slowly introduce it to school so that, gradually they're not overwhelmed like, oh my God, I always have to use the tab. I always have to carry it. So first you start at home. Once they're very comfortable with it, then you take it outside, wherever they go, park or shopping or mall or anything that you do. And then you introduce it to school. So that slowly they get comfortable that it just becomes a part of their routine.
And Miraclyn, what advice do you have or what suggestions you have for other fellow occupational therapists who are just starting to incorporate AAC into their practice, or who you think should have more communication support in their sessions?
Okay, so the first and the main thing that I would like to tell my fellow OTs is that, get out of your comfort zone, because we're so comfortable in the way that we take sessions that we sometimes we think like, okay, if we use the tab, that's just going to waste some of the time, waste the little time that I have for my session. Because the child does not know has not learned properly how to show picture or everything, and then it takes time. So we just want to like, okay, this is the goal for today and this is what I want to do. And also we are very hesitant to use an AAC device because, again, I thought it was just a speech therapist's job to train the child with AAC until I started using it. I started learning how to use it, and I saw the difference that it made in the therapy. So again, knowing that, okay, it's not just a speech therapist's role, it's also OTs. We can also use it in helping them communicate. So that requires us to learn something new, get out of our comfort zone. It's okay, even if it takes a lot of time in your session, for a child to communicate, but that's okay. At least in that session, the child will feel content that, okay, my choices were given priority. I was able to tell what I felt to my therapist, and that was taken seriously, or that gave importance. So yeah, because uh, a non-speaking child is not a non-thinking child, because a child is constantly thinking of different ways to put across what they are thinking. And when we use this device, this AAC device in our settings, it increases their way of communication. They would be able to tell you that I'm feeling frustrated with this activity. I do not want to do it, or I need help to do with this activity. Because most often, if they are throwing a tantrum or if they're having a meltdown, we always think that, okay, it's behavioral, or like, they don't want to do it. But when a child is able to communicate saying, I'm frustrated, I am not able to do it, or I'm feeling difficult to do it, then we also understand, okay, so they require help, or we may have to grade the activity down a little bit for them to do it. So that is one thing. And then research, watching videos about how we can use AAC in our sessions. And again, if you have a setup where a speech therapist is working with a child with AAC, observing their session, seeing how they are using AAC with their child to communicate and how they are responding to it, those all helps. And again, collaborating with speech therapists and AAC technologists, and involving the family, asking them also to sit in the session and trying to do it together. And you can start small. Again, like I said, you don't have to use AAC for an entire session when you are starting. Maybe for just choosing an activity first when they come home, maybe just saying hello. You can just use an AAC to say hello, and then you can tell them this is the activity. Yes, no, that is enough. And then slowly you can bring in to ask their thoughts about the activity that they've done, or how difficult it was, or how easy it was, then introducing it. And personalizing and learning what all modifications the child requires for the AAC. That also helps them. And at the end, when you have started using AAC, evaluate periodically. You need to see how much improvement the child has, and the AAC also has to be customized based on their improvement. When you are starting, maybe the child does not may have had difficulty in touching the picture. So what you would have done is increase the picture size. But once the child has learned to touch correctly, you have to grade it up. You have to minimize the picture so that you can add more pictures in that. Like I've heard a talk, they said language is not just 3 or 4 words. Okay, so if you are maximizing it to just keep 3, 4 pictures in one page, the child will have difficulty in moving through pictures or moving through pages to find the picture. Again, once the child has acquired the skill, you bring it down and then you train them in that. So evaluate and grading it up is another thing. So these are the tips that I would like to tell.
In Miraclyn, how do you stay current with the latest research and all the advancements of this AAC technology?
So again, reading new articles, so subscribing to journals or articles which have more of AAC. So there are so many pages, there are so many AAC programs, apps, and so many research papers that have come up. So maybe we can subscribe to that and then read up, and then attending workshops or conferences where they teach you on what more we can do as OTs with AAC for children, training, and collaborating with other professionals. So it's not like we learn everything in a day. We learn every day. So talking to speech therapists, and if there's any doubt or if we are hitting a wall, then asking them like, how can we use AAC, or what should I change in this, and bringing them into sessions and asking them to help out, and involving in discussions, professional organizations where they use AAC, and talking with them, and those all help to keep up to date in the current trend.
Okay, so Miraclyn, as we are coming to the end of this interview, I want to express my gratitude to you for sharing all your insights on AAC and all your expertise of how you impacted the children whom you have worked with. So your insights into the importance of this, we just would like to see a video which you can share in using your sessions.
Yes, I would show the videos.
To paint dolphin or do you want to color ship? Can you type and show me? Okay, so we'll do ship.
I have 2 more videos. I'll just show that also.
What color is 3? Can you type? Very good. What color is 4? Can you type what color is 4? What is the color of 4? What is the name of the color? This is, can you type the name of the color? Very good. Can you type the color 5? What is the color of 5? Very good. Now take green. Can you type the color? Brown. Good job. Okay. Can you type what color is 7? Pink. Good job. Let's take pink.
So this is, this was a session that I took with a child, so using AAC. So that again, she was able to make a decision on what kind of coloring that she wants to do, and again that also that back and forth communication of me asking her what color and which color that particular number was, and her answering. So that participation is what I wanted to show through the video.
Yes, that really makes sense how to communicate. She's actually having a two-way communication with you.
Yeah.
Yeah, makes sense. And dear Miraclyn, I truly appreciate your time and contribution to this important discussion. From our audience behalf and from the team behalf, I extend my heartfelt thanks for your valuable insights and expertise. So we are ending this interview now, and we hope that our audience gain a clear understanding of AAC and its vital role in empowering individuals with autism to communicate effectively. By addressing misconceptions and promoting a shift in mindset, we can provide the support needed for every child to have a voice. Let us all work towards creating a world where everyone can express themselves freely. Thank you, everyone, for joining this. Have a great day. Bye-bye.